I'm Dr. Vivek Viswanathan. I am basically a pediatric urologist and a minimally invasive pediatric surgeon. My area of expertise is specifically pediatric urology. I've got a lot of interest in laparoscopic and robotic surgeries. I had trained for it immediately post my MS. So I used to do bariatric surgeries previously. And once I did my super specialization, I've got specialized training for robotic surgery in children as well. I was working at Kokilaben, Dhirubhai Ambani Hospital in Mumbai, where we had a huge bulk of pediatric surgical cases which we had operated robotically. It was one of the largest robotic surgical programs for children in the country. And now for the past 1 year, I've come back to my hometown, which is Vadodara in Gujarat. And here I have been practicing as an exclusive pediatric urologist. See, essentially, daycare surgery means a surgery of short duration, that anything that can get over within the day itself. It was a concept which started in the early 1900s, especially 1909 by a guy called Nicole. In Iowa, the first outpatient clinic was started in the early 1920s. Children predominantly being healthy as expected most of the times and usually requiring surgeries that need short duration of stay only. It is better that we use their admission as and use them for daycare surgeries. Most of the common ailments that they suffer from are amenable to daycare surgeries, and that is one of the areas of interest, and I am actively trying to promote it as well here in my center too. Yeah, so the commonest and the most widely used one is circumcision. Now that can be of two types. It can be either ritual circumcision in Muslim kids or those for kids who have phimosis. The other common ones include surgery for hydrocele surgeries. Okay, your surgeries for undescended testes, some lymph node biopsies or rectal biopsies that you might want to do. If you have a few cysts or lumps that you want to excise and send for biopsy. Several ophthalmic surgeries like duct probing, adenoidectomies, quint repair, lens implantation, tongue tie release. All of these are very easily amenable to a daycare surgery. There are a whole list of more. Even tonsillectomy can be done in a daycare surgery. There is practice which is coming now of you actually operating surgeries which would require a longer stay as a daycare procedure and sending the child home with the catheter or something in place also. That is increasingly being adopted. I mean, it varies from procedure to procedure. A circumcision, for example, would take me anything less than 10 minutes. A herniatomy or a hydrocele surgery for the same would be less than half an hour duration. An undescended testis would take me a good 3/4 of an hour or so. But usually, the longest of these surgeries would vary from anywhere max from 10-15 minutes to an hour and a half at most. If you want to classify it as daycare surgery, the anesthesia would also have to be something from which the child can recover in time to enable you to send the child home. So the longer the duration of the surgery, more the duration of the anesthesia and prolong the recovery, which you don't really want. So usually the surgeries get over within the hour. By and large, almost all the procedures in children are done under general anesthesia. Now, they can be short general anesthesia, but general anesthesia is preferred. Unless the child has some absolute contraindication to it, general anesthesia is preferred, even for a procedure like circumcision. You might supplant it with a block which would take care of the local pain after the surgery as well, but almost all are done under general anesthesia. See, look, essentially, like I said, most kids are expected to be healthy without any major comorbidity, right? There are a few exclusion criteria in children who you should absolutely not take for daycare surgery. Every other kid is actually amenable to undergoing daycare surgery. So these include an extremely preterm infant whose post-conceptual age also is still less than 50 weeks. Means the child has been born and the total age is still less than 50 weeks. So that child is not amenable to daycare surgery. If the child has got a major systemic disease or a major cardiac disease, it is very complicated, then the anesthesia becomes a risk factor, so you should not take the child for a daycare surgery. Sometimes if the child has got a cardiac murmur, right, and the child has not been investigated for it, you have found it in your routine assessment of the child, that child should not be taken. Diabetes, as always, though rare in children, if the child has one, you should not take him for a daycare surgery. Children with sickle cell disease, because that can pose a problem in terms of clotting, those children should not be taken for daycare. And if they have some breathing issues in the terms of sleep apnea or something which is already documented, they should also be excluded. Barring these, if there is an active bacterial or viral infection going on, that is a contraindication to not only daycare, any general surgery under general anesthesia. These are the ones which will exclude the child from getting a daycare surgery. Otherwise, almost all other children can be taken for daycare surgery without much ado. Chronic conditions, major systemic conditions like heart diseases or major lung issues or something of those sort. Yes. So essentially, see what we'll do. Let's take the example of a child who has got, let's say, a poorly controlled systemic disease. Okay, so what you would do ideally is get the child admitted maybe to the pediatric intensive care unit or the neonatal intensive care unit, as might be the case. Do a thorough investigation of all the systemic diseases that you want. Get a pediatric fitness for the same. Do it under due risk and keep the child for observation post the surgery also. In a daycare, what essentially happens is once the child wakes up from surgery, after the anesthetic has worn off, you immediately start the child on oral feeds, and once the child has passed urine adequately and is free of pain, we discharge the child. So essentially like 2 or 3 hours post surgery. With a child with a systemic disease, that's not a risk you can take. You'll probably need to keep the child maybe a couple of days to see whether the child is progressing well post surgery. So that's the difference. The preoperative assessment is a lot more extensive. Sometimes for daycare surgeries, what happens is the anesthetist sees the child. I'm particularly talking about India on the morning of the day of surgery. Whereas in cases which are actually contraindications to daycare or for planned surgeries where we expect a longer wait, the anesthetist would have done something called a pre-anesthetic checkup, where they would have assessed all the risks and the complications they expect to the parents, informed them to the surgeon, and told us to take these necessary precautions, arrange for blood or blood products or whatever. So that is how it differs. So essentially, the investigations that we need for surgery are something called as investigations needed for fitness for surgery. Now that include a simple hemogram, that is a CBC, complete blood count. You need to see whether the child will stop bleeding if you put a cut or not. So that is got by bleeding and clotting time and the prothrombin time, right? PTINR. Because the anesthetic drug tends to get eliminated through the kidneys, you need to get a serum creatinine and you need to get a AAA, that is the viral markers, to be allowed into the operation theatre. So these are the ones that I routinely get. I don't get anything more. No X-rays, nothing, unless the anesthetist warrants it or the child has got some lung condition. Whether we need a sonography or not depends on what the child has, right? If the child has a hernia, I'm not very sure that it's a hernia. Most cases it is obvious, right? But I somehow just want to document it, I might order a sonography or something of that sort. But by and large, just the routine blood investigations of which I've mentioned, these 3 or 4, these are the ones that I ask for, and the anesthetist is fairly happy with them. They don't usually ask for more. And these again, if you get it done within the month of the date of surgery, that is enough. No, they are not. They are not required. What we usually do is just call the child for a follow-up after a week, and that is that. If we do something for an undescended testis, okay, and if we feel post the assessment on follow-up that the testis is not where it should be, might be that I might get a sonography, but that's not a routine. So there are no routine investigations that we do for daycare surgeries that are done by and large. So essentially, I'll tell you exactly what I tell my parents when they ask me this question. Daycare surgery, by the very name itself, suggests that the child is fit to go to school or resume his activities from the very next day. Okay. But see, you have to realize that they are kids after all. They'll be going to a school where there are other kids, right? So even if the kid takes all the necessary precautions to avoid injury, the other kid somehow may unknowingly throw a ball. The desk might hit him. Knee might hit him where he has been operated. So what I usually advise them is to just avoid going to school if possible for a week, but technically they can resume all normal activities from the next day. There is no contraindication to bathing or anything because the stitches that we take are all absorbable by and large. The dressings that we put are washproof, so taking a shower is not a problem, and the stitches don't necessarily need to be removed also. So as such, there is no care that the parent has to take it, and the pain is also managed very well. No, hard nose. See, for example, if I were to operate on an undescended testis, so I have placed the testis now in a sac which I have created in the scrotum. What I would advise the child is to avoid cycling for a week or so because it might hurt. That is one of the things. Don't lift heavy weights. Okay, avoid injuring yourself in that area. Those the normal things. Nothing very specific. Nothing very specific. it is a surgery, complications are expected, but by and large, because the procedures themselves are not too complicated, let's put it that way, the complications expected to are minimal. With any surgery, the three important complications you can expect are pain, bleeding, and infection. Infection you would only know on follow-up. Pain and bleeding you would know immediately. There have been instances, obviously, in my surgical career where sometimes the child has bled. Okay, sometimes you have had to take a longer time. Sometimes the child took a longer time to recover from the anesthesia, and so we had to keep the child for a bit. And sometimes, because the child was operated later on in the day, it changed from a daycare to 1 day stay. So those things have happened, but by and large, they are not really a life-threatening. How would you classify the risk? If you were to talk about anesthesia, pediatric anesthesia has evolved a lot from what it was previously, let's say a couple of decades back. It is absolutely safe. The child goes in and he comes out exactly the same way he went in, awake and talking. When the child comes out from anesthesia and comes out of the operation theater, he's awake. The parent can actually sit and talk with the child. And like I said, it's a surgery, but most of the surgeries are not very major or complicated. Otherwise, they wouldn't be daycare in the first place. So routine surgical risks are always there, but by and large, they are not life-threatening. We have operated on neonates, that is a child less than a month also. Okay, but it is advisable to keep such small children for observation for a day because their physiology is markedly different. Having said that, even children less than 1 year can technically undergo daycare surgery, although that is not commonly done. Any child above 1 year, you can absolutely safely go for daycare surgery. With a daycare surgery, it's not actually required. What you really need to see is how the child awakens from anesthesia, if the recovery is smooth, if they are awake, if they're able to take feeds well without throwing up, and if they have passed urine, everything comfortably, I send them in. If I were to not do it as a daycare and if I were to do it instead as a 1 day stay, would that change? No. The long-term outcome is not going to change. Whether I discharge the child within 6 hours or whether I discharge the child after 24 hours, it's going to remain the same, right? With any hernia, the chances of recurrence are 1 to 2% in the best of hands in the world, wherever you get operated. That is going to remain the same. If you have a hernia on the right side, the chances of the child having a left-sided hernia lifetime remain 10%. That risk is always going to remain the same. That's not going to change. So, I mean, what is not going to change is not going to change whether I do it as a daycare or as a long duration or a long stay surgery. So, I mean, I think that this myth is confounded. I can see where this comes from. See, because when you keep a patient as an inpatient, you give IV intravenous medications, right? And technically also, it has been proven that intravenous medications act faster. But most procedures that we do as daycare are very, very easily managed with the routine doses of painkillers that we give. And that too, the requirement is barely a day. In worst cases, a couple of days. I do not prescribe painkillers for more than 48 hours. After that, it becomes SOS always. And it is the simplest of painkillers, crocin, that is paracetamol, which is given. The pain is very well controlled in most cases, unless it's a fracture. Orthopedic procedures can also be done as daycare, in which case the pain might definitely be involved. In the setup that I am currently, I although I am a pediatric urologist, I have to do general pediatric surgery also. So I do both in the setup that I am. Okay, so what I get is circumcisions, I get hernias, hydrocele, undescended testes. I get a lot of PUJ obstruction, that is pelvic-ureteric junction obstruction, that is the kidney not functioning properly as it should. Vesico-ureteric refluxes are fairly common. Urinary tract infections and assessments for them are common. I get a lot of hypospadias where the urinary opening is somewhere down on the penis and not where it actually should be. That is fairly common. That is something that I get quite a lot. Then there are quite a lot of lymph node biopsies that I do as a pediatric surgeon. And there are quite a few cystoscopies. That is, you put a scope in and see what is wrong with the bladder when the child gets repeated attacks of UTI. That is done. Stone is not very common in children. Stone disease is quite rare. And there is the occasional posterior urethral valve, but that is in neonates. These are by and large the chunk of my diseases. There are quite a few rare ones, but not worth mentioning in the sense that I get hardly 1 or 2 every 4-5 months. If it is less than a 1-year child, we usually do not prefer to do daycare surgery, especially if it is for something called ritual circumcision. Now, parents would obviously want the child to be operated whilst the mother is still in the hospital. So within the first 2-3 days of life, theoretically you can do it. but that is not preferred by most, at least not preferred by my consultants, not preferred by a lot of other people who I'm worked with. What we usually prefer is to do it after 1 month when the child is able to tolerate the anesthesia. But if they insist, you can actually still do it. I have operated 4 or 5 cases here itself when the child was less than 48 hours old, so less than 2 days. Recovery was also fairly smooth, but it is not preferred. Why subject such a small child to so much pain when it is not actually indicated? It's not an emergency surgery. An emergency you can't avoid. It is something that you're doing as a planned procedure. So it is better that you let the child grow to 1 month of age and then do it. Apart from that, per se, age does not make a difference, really. It is advisable though that children less than 1 year of age, you actually just keep them for observation for a day. Their physiology is slightly different from older children. No disadvantages per se, but now see, we are talking about a country like India, right, where not everybody has access to all the facilities. In a daycare surgery, the premise is that the parents can take care of the child post-surgery at home. When you operate on a child and you keep the child in the hospital for the next couple of days, the onus is on the nurses and the doctor to take care. When I send the child home after a daycare surgery, the onus is on the patients. Now, quite a few of the parents might be illiterate, they might be laborers, they might not be as conversant with what you have told them in terms of taking care of the child at home. Some of them might not even have the resources to go back from when they have come to get the surgery. So that is one problem. I usually love to see the child 1 week after I have operated. Now, if they have come from a far off place, that might not necessarily be possible. That becomes a problem. So these are the minor blips. Sometimes if they do not understand what I've tried to tell them in terms of pain management, then they get very flustered that the child is constantly crying for the first day and all, and then I get a whole lot of calls. So that tends to happen, but not very often. I have been singing Hindustani classical vocal and playing the tabla since I was 5 years of age. I have got bachelor's degrees in both, and I won the youth festival also. Essentially, and my grandparents were from the Carnatic side of music. I've learned Hindustani classic. So what that does is essentially give me a calming perspective. If you have read on the blog, what it actually tells you, the tabla is very precise, right? Tabla is very precise. So it essentially tells you that every stroke, every cut that you give on the child has to be precise and to the point. You should not make it more, you should not make it less. That is one thing that has done. Music always calms me. I do not have any one specific genre of music. It's not that since I have learned classical, I only listen to classical, I listen to pop, I listen to everything except hard rock. But what that does essentially, I prefer to have something going on in the background. It was the same when whilst I was doing my medical school, it was the same at school also, it's the same now. What that does is something is going on, it keeps me focused on what I'm doing in front of me. And that helps me in that way, and plus it calms me if I'm stressed. If I'm stressed, I take a moment out, I listen to what the wordings actually are, and then refocus. So I mean, it has helped me. Everybody has their ways and things. Music does help me quite a bit. Yeah, essentially, surgery is a very high stress environment. You need to understand, if you've been in quite a few theaters, you will realize that surgeons are, most of the time quite frustrated and angry and shouting and all. See, because it's a high stress environment, essentially. Somebody's life is literally in your hands, right? So music, upbeat music or light calming music certainly helps keep the mood down. Quite a few times surgeons and anesthetists do not get along. It's quite a well-known fact. Music in that moment might help to calm you down. And this is all from personal experience, look. But I have seen it in almost all the theaters that I've worked with. Almost all my colleagues, my peers, my seniors used to love working with music. The genre might be different, the kind of music might be different, but essentially most of the places where I worked at, there has been some kind of music. In our country, unfortunately, the uptake of surgeons opting for pediatric surgery as a super specialty, is very less. If I were to quote my own example, in the year which I took my super specialization, there were only three others who took it. Now that's a very dismal number considering that there were at least 55 seats that went vacant that very year. And by and large, if you see, hardly anybody opts for it as a first choice. I took it as a first choice. But there are very few who do it as a first choice. It's either if you have been there for years and you're not just getting anything and you got it as a last choice, or if you already have a setup and then you want to continue with it. So that is one thing. What you also need to understand is that children are not small adults. Their physiology, the way you need to deal with them, the problems that they have are radically different from the ones that we face. So you need somebody who's actually well versed. whenever anybody asks me what were the trials and tribulations you faced when you were training to become a pediatric surgeon, see, the thing I always tell them is for the first 4 months, I had to unlearn everything that I had learned as a general surgeon. It is totally different. I had to essentially forget what all I had learned, relearn everything again, and then tailor it to a child's body. A pediatric surgeon not only understands the kid's physiology, but they know how to deal with it. The conditions are different. Since they are used to dealing with tiny things, they might be a little more meticulous. I'm not saying adult surgeons don't do a good job. No, not in that way at all. But some things call for expertise, and this is one of them. And social media now, the commonest thing that everybody looks to is reels, right? If you use social media, that's the easiest form of consumption because you don't really have to use your mind. If I were to post informative reels, make it entertaining, somebody might just go down to my blog and read it, and that can increase awareness. So that is something that I've been trying to do. I try to post reels on topics that I think should be useful for parents. I don't want to monetize them. I just want to spread out information. So I have my blog on my website. I have a Spotify podcast too, and I try to upload videos on YouTube. So this is how I'm trying to do it. Hopefully it goes someplace, and hopefully we have more pediatric surgeons in the future. Yeah, again, so when you think your child is suffering from a surgical problem, rather than rushing to your known surgeon, it would be best if you looked for a pediatric surgeon and sought specialist advice. Because again, like I said, they can handle your child a little bit better, wee bit better than the other adult surgeon. That is one thing. Children again are not young adults. Their management is different, and most importantly, a mother should trust her gut. I trust the mother's instinct more than I trust my own clinical skills. If the mother tells me that something is wrong, I take a second look at the child, even if I think the child has no problem. Because the mother is more often than not always correct. Your instincts are always best. So if you as a mother feel that your child is not well, please go to a doctor. If you're not satisfied with that doctor, take a second opinion. There's nothing wrong with taking a second opinion for you. As a surgeon, it took me a while to be with different babies to know their different cries. Okay, so a baby who is hungry cries a little bit differently from when he's peeing, the same thing when he's pooping and when he's in pain. A mother who is with a child 24/7 would be able to pick this up in a flash. So the mother would know that child has probably got some problem. Okay, she might not necessarily know where the pain is originating from or whether the child has some issue, but that the child is not well. So trust, like I said, trust your own instincts. A mother or the father or the caregiver, in our country, grannies also know very well that there is something that's not quite right with the child. If the child is incessantly crying, you have tried feeding the child, you have tried pacifying the child, you have tried playing with the child, you've done all the routine things, but the child just simply cannot be pacified, rush to a doctor. There's no harm in just going to a doctor and finding out that the child is normal, fine, parent. But children don't give you enough time as adults. So something might go from this to absolutely crashing in a minute. And I've had this worst experience when I was training. Sometimes in the initial phases, you don't realize why the child is crying. So you might assume that a child is just crying out of hunger when the child had a major problem and the child immediately crashed like anything. So over the years, I have learned that you should never ignore a child's incessant cry. That's one thing. Okay, if the child is refusing to feed completely, there is something definitely that's problematic. If you have not overfed the child, there is no reason the child should refuse feed. Every time a child is hungry, which is at routine intervals, they do feed. They'll feed, they'll pee, and then they'll poop. That is a routine. If the child is not sleeping normally, okay, if the child is throwing a persistently high-grade fever, by high-grade I mean anything above 100 degree Fahrenheit, then these are signs you should be bothered about, and then you should show your pediatrician or a surgeon, whatever you think fit. The reason why most of the people don't opt for pediatric surgery first, and I am being absolutely honest about it, is the money. Pediatric surgery is one of the specialties of super specialties which does not give you as much money as some of the others might give you. That is one thing. The other, because like I have said, you have to relearn everything from scratch. You've already spent a good 3-4 years learning surgery and working so hard day and night. You have to labor again. Okay, pediatric surgery is double, triple the work that you had done in your surgery because you are dealing with small little babies who do not, like you very rightly said, know the way to express themselves. So you have to look for the cues, you have to look for the signs that they are showing to find out. If you are in a very busy setup like the one I have trained at, where there are 70-80 kids admitted all at one go, it really is a handful, right? And there are very few actually good centers, so that should not be a discouraging factor. If you work hard enough, if you do good quality work, there is enough money to be made where you can lead a comfortable life. That is one. Pediatric surgery, if you are genuinely passionate about it, you can actually make a very good living and have good peace of mind. I am absolutely happy that I took pediatric surgery, because I get to see happy babies in front of me, and that gives me a good night's sleep. That is my main motive. So if that is something that you are looking at, you will certainly go into pediatric surgery. Yeah, it is hard, but no super specialty is easy. So if you are willing to put in the work, pediatric surgery is an absolutely brilliant field to go in. And apart from India, everywhere else, it is regarded among the top 2-3 super specialties. So, and now with increasing awareness, with increasingly people resorting to social media, to Google, to research about things, people are realizing the importance of going to a super specialist for their kiddos now. So we have started getting more and more parents who come to us now directly, rather than going through a surgeon and then coming to us. So the scenario is improving, and that should be also kept in mind.